Okay, just a couple things before we get started. I know in your calendar it says facial bones and orbits. I'm not going to do that. I'm going to do facial bones and sinuses. Normally when I teach this, it's facial bones and sinuses, but that was when I was in Warner Robins. And so when I came to the North Campus, they were doing it facial bones and orbits together. So I feel like mandible and orbits should go together more than facial bones and orbits and mandible and sinuses. So we're going to kind of follow the book, how they do it. Everybody did, I thought, fairly well on their tests. What did you guys think about the test? For a skull.
It was okay.
I reserve my thought.
That's how your next couple tests are going to be on cranium. There are going to be a lot of films to look at, a lot of films to identify, a lot of anatomy to identify. Make sure you're reading those pink boxes where the projections are, because that gives you a lot of information about targeted anatomy and what you should be seeing. And if the anatomy is not seen the way it's supposed to be seen, what caused that? So just make sure you're also studying those. It's a lot of information, but it's going to be on your test. It's going to be on your registry. I also wanted to say that the CT content that was supposed to be scheduled for the end of this class, I don't think I'm going to do that. It is not per the standards that you have to go over that chapter, and I think Ms. Cobb has already covered CT. It won't be on your registry. That CT stuff won't be on your registry. You know, it will be as another modality, but it won't have questions pertaining to exams in CT. So I don't feel like I want to waste time on that. What I do want to do is revisit some more of the cranium, especially the cranial anatomy. But as we get closer to that, I'll develop something. So we're not going to do the CT stuff, the CT chapter. All right, I'm going to get to it. Now, luckily, a lot of the projections that you learned for cranium or for skull is going to carry through to facial bones and sinuses. You're only going to have to learn just a couple new projections and where the centering is supposed to be. So that's good news. All right, so I like sinuses. Sinuses are my favorite. I like orbits too, but I really like sinuses. So I'm excited about sinuses. All right, facial bones. You have 8 cranial bones and 14 facial bones. You have 2 maxilla bones, which make up the maxillae, the maxilla. Those are the largest immovable bones of the face, which means that they don't move. Your mandible is the largest bone in your face that moves. That is the only bone that should move. 2 zygomatic bones, 2 lacrimal bones, 2 nasal bones, 2 inferior nasal conchae, 2 palatine, 1 vomer, and 1 mandible. Those are your facial bones. Again, like I said, I'm going to break down mandible to go with orbit. We're not going to do orbit with facial bones. All right. So the maxilla, you have right and left. It consists of 4 processes. You've got your frontal, alveolar, zygomatic, and which one am I missing? Frontal, zygomatic, alveolar. I say nasal.
It's the palatine.
The
palatine process.
Palatine process. Is that Kate?
Yeah.
Thank you. I knew I was missing something. The frontal process obviously projects upward along the lateral border of the nose, along the frontal bone. So that one's fairly easy to remember. zygomatic process projects laterally to unite with the zygoma. Now remember, you also have a zygomatic process off of the temporal bone. So don't get those two confused. It was easy to get confused when I was in school. I had to really, really sit down and separate both of those. The alveolar process is inferior to the body of each maxilla. So it's the one towards the bottom where all your teeth sit. Their anterior nasal spine, the two maxilla are solidly united in the midline here. Okay. It's also referring back to my notes. That's why I keep looking back and forth. All right, frontal view. So again, take note of all these processes. The palatine process you can't see from the outside. You'd have to actually take the skull apart and look up underneath. The frontal process extends up into the frontal bone. Again, that's why it's named that. Zygomatic process, there's a zygomatic process here. And again, on the temporal bone, the alveolar process, bottom of the maxilla, where the teeth are. So I've repeated that twice now, so probably a pretty big deal. So I'd probably remember that. Here's your palatine, hard palate, the inferior surface. This is the fourth one. Of course, you can only see this one through the interior or inferior view. It is called the hard or the bony palate. The two palatine processes from the anterior portion of the roof of the mouth. Okay, so I know we're all familiar with the cleft palate. We've heard that, you know, just in for general knowledge. But the cleft palate is when the opening between the palatine don't fuse correctly. The two palatine bones don't fuse correctly, so you have that cleft palate. And the maxilla articulates with the frontal and ethmoid cranial bones and 7 facial bones. So I would probably know those 7 facial bones. Zygoma, the lacrimal, nasal, palatine, inferior nasal concave, vomer, and the adjacent maxilla. Of course, you can also see here, you've got the pterygoid hamulus of the sphenoid. Remember that from whenever we went over skull. All right, zygomatic bones. That's articulate with 3 cranial bones and 1 facial bone. The zygomatic arch forms your cheekbone. That's what you can feel right here. That's the zygomatic arch. When people are applying makeup to the apple of their cheek, that is the cheekbone there. Some people have more prominent zygomatic bones than other people. It's not fair, but they do. It's located lateral to the zygomatic process of each maxilla. And it projects posteriorly from the zygoma, a slender process that connects with the zygomatic process of the temporal bone. It is very delicate and it is easy to fracture if you've been hit in the face with, I don't know why, maybe you play baseball, maybe you made someone mad, I don't know. If a baseball were to hit your face, or if someone should punch you in the face, or if you were maybe to fall on your face, it's fairly easy to break the zygomatic bone because it's very thin right here. Let's see. This one articulates with frontal and temporal bone. Those are your cranial bones and the maxilla. Posterior portion of the arch is formed by the zygomatic process and the temporal bone. Okay, so I would remember that. You've got your zygomatic arch there in the image, the prominence, and this actual zygomatic bone. But the temporal bone is back here, if you can remember. All right, your little nasal and lacrimal bones are very small. They're the thinnest and most fragile bones in the body, very thin. The lacrimal bones, the size and shape of a fingernail. So really small. They're very small, very thin, especially if you have thin fingernail. You can sort of tell how thin that is. It's posterior to the frontal process of the maxilla. Okay. So it is derived from the word for tear because they're closely associated with the tear ducts. They're right next door to the tear ducts, so they just call them the lacrimal bones. So if you can remember that lacrimal is associated with the word tear, you can pretty much reason where they are. The nasal bones, very, very tiny. I don't know if anyone's ever had a broken nose. I've never had a broken nose, but there's not a whole lot you can do for a broken nose. I mean, you can reset it, push it back over, but those bones are so tiny. There's not like you can go in there and put staples or wire and kind of pull them back together. They do form the bridge of the nose. It's right here. Not down here. That's cartilage. Just right here. You can feel the bone where the bone stops on the bridge of your nose. So they lie anterior and superomedial to the frontal process of the maxilla. Now, we all know that the nasal bones can be a little bit larger in some people than other people. So a lot of times that's genetic if someone has very large nasal bones and they have just a bigger nose. Of course, I would know the lacrimal articulations. Those cranial bones are the frontal and ethmoid, which you can, clearly see there how close they are to the ethmoid. Two facial bones, the maxilla and the inferior nasal concha. And the nasal articulates with two cranial bones, ethmoid and frontal too, and the maxilla and adjacent nasal bones. So you have two little nasal bones in there. Nasal conchae, these are called turbinates. I think you had a question on your last test about what is not located. I can't remember where in the skull, but it's the turbinates. Most of y'all got that one right because the turbinates are in the nasal area. These are the scroll-shaped looking bones. They do look like they're just kind of carved out of wood, just kind of nice scrolls. They project from the lateral walls of the nasal cavity. These are needed to break up the nasal cavities into multiple sections. You have to have these nasal concha. The reason why they're scroll-shaped is because it allows for air when you're breathing in to circulate through the different areas to get warm before it enters your lungs. There are mucous membranes that coat these concha. So it's also moist air that you are inhaling after they pass through the nasal concha. So those are very important. Here's your right and left palatine bones. These are L-shaped, and they're hard to see. They're internal. So like I said, you have to break apart a skull to actually see the two palatine bones. But they do make up the hard palate. That's the roof of your mouth. The inferior nasal conchae articulate with ethmoid and maxilla, lacrimal, and palatine bones. All right, so you can see from the image the nasal conchae and the palatine bone. I don't know if you can see my cursor, but it's this L-shaped right here for the palatine. I know, I'm sorry. This anatomy is boring to me too. I mean, just kind of because you just have to learn it. But the bony nasal septum and the vomer. You can see there the perpendicular plate of the ethmoid, your septal cartilage, and the vomer. Ethmoid and vomer form the bony nasal septum. The septum is formed superiorly by the perpendicular plate, which you can see that. And the septal cartilage is located anterior, and the septum is the cartilaginous part of your nose here. The vomer bone means plowshare. It's thin, it's triangular. It forms the infraposterior part of the nasal septum. So I know we've all heard of deviated septums. That's when the septum is deflected or displaced laterally from the midline of the nose. So it's not straight, it's kind of bent a different lateral way. So it can make it difficult to breathe. For some people, they may have chronic sinus infections because of it, because it's not shaped the correct way. Again, severe deviation can block passageway of breathing and make it almost impossible. So a lot of people have deviated septum surgery. A lot of them, well, also if they're not happy with their nose, they'll come out with a better looking nose and a fixed septum. All right, I'm going to skip over the mandible. Those are the next couple in the slideshow that is posted on Blackboard. So I have gone directly to joint classifications. Don't forget about those mandible slides. I will come back to those when we go over mandible. All right, so sutures, fibrous, synarthroidal, which means they're immovable. Now the alveoli and the teeth are fibrous with the gomphosis subclass. The gomphosis is the joint that binds the teeth to the tooth socket. So that is, I think, the only place in your body where you've got gomphosis joint classification. Okay. And synarthroidal, which means immovable. TMJs, we'll come back over to those, but of course you can tell in yourself that those are freely movable. You can open and close your mouth and feel them move. All right, so I'm going to go into the sinuses. Does anyone have any questions that I can answer about facial bones besides mandible?
No, ma'am.
Okay, because I know, I'm sorry. I'm so sorry. I've got some worksheets for you guys on campus so that you can hopefully learn this stuff. This stuff is very difficult to get all of this information. All right, anatomy of the paranasal sinuses. All right, these are those large air-filled cavities in your face. I love the sinuses, unless they're acting up. Because they're hollow, these have to be done erect for air fluid levels. So if in the event that your patient cannot be erect for any reason and they have to lie flat on the table, it's going to be a cross table beam. It's not going to be a direct beam because you still need to see air fluid levels. They are lined with mucous membranes also to keep them moist. Now, a lot of I don't know, doctors or scientists they really don't know the exact reason why we have sinuses. But the general consensus is it's also to help lighten the bones of the head. All the bones in your head are very heavy, sitting on, your neck. So it helps to kind of aerate the bones in your face so that they're not quite as heavy. You have the maxillary, the ethmoid, frontal, and sphenoid sinuses. So those are your 4 groups. All right, of course, your maxillary sinuses are named for your maxilla because that's where they reside. They're above the upper teeth. A lot of people, if they're having sinus issues, will be in the frontal sinuses or the maxilla. And a lot of people will complain of pain and swelling right here, right up under their orbits because their maxillary sinuses are filled with fluid. These are the only sinuses in the facial bones. Okay, so that's a little tidbit you probably might want to remember. The other sinuses are not in the facial bones. This is the only one. All right, so there is definitely communication between the sinuses and the nasal cavity. The nasal cavity is divided into 2 chambers called fossae. You can see here the purple, right here, the 2 cavities. Now, I don't know if anyone has heard in the past of some type of brain-eating bacteria Well, that's how this happens is if you are swimming in contaminated water or pond water and you take fluid into your nose by accident, guess where a lot of that fluid is going to end up? In your sinuses. And your brain is right there. So if you've got any type of nasty germ or organism that has made it into your sinuses, there's potential for it to get into your brain. I know, lovely. All right, your frontal sinuses. Yeah, they're between the inner and outer tables of the frontal bone. These rarely become aerated before the age of 6. Now, the frontal sinuses are a little bit different because they are rarely symmetric. They can be singular or paired or absent, not really there at all. Of course, named for the bone, they're in the frontal sinus or frontal bone. And on x-rays, you'll notice that these are going to look different on every single person. These are not going to be characteristic like the maxilla sinuses are. These look very different on everyone. But generally, most people have 2 frontal sinus cavities. Most people do. That's why it says number varies. It could be 3, it could be 4 different cavities, but most people have 2. Your ethmoid sinuses. So these are the air cells grouped into anterior, middle, and posterior collections, but they do all intercommunicate. So that's why your 3 collections there. They do fill the orbits on the lateral view because portions of the ethmoid sinuses are contained in the lateral masses of the ethmoid bone. The anterior of the ethmoid sinuses appear in the orbits. These are very difficult to see on most x-rays. This is why you have to do the lateral image, especially to see the ethmoid sinuses because they're behind everything else. All right. These are below the sella turcica, the sphenoid sinuses are. So even if you can't remember where exactly these may be, you know for sure that they're in the sphenoid. They're sphenoid sinuses, but they're below the sella turcica, the saddle that you see on the lateral skull X-ray. You can have effusion in your sphenoid sinuses, and they are asymmetric as well. So blood or cerebrospinal fluid can leak through any type of fracture or basal skull fracture, and then you'll get your sphenoid effusion. So that's a good indication. If you've got fluid in your sphenoid sinuses, you've got some type of fracture somewhere. So they can sort of further diagnose if you've got some type of skull fracture. Those normally don't, the sphenoid sinuses don't normally fill with fluid. They're not like the maxillary or the frontal. So if you've got fluid in those sphenoid sinuses, you've definitely got some type of pathology. The osteomeatal complex. This is a coronal view. So just take a good look at this. Of course, you can see the ethmoid sinuses, the middle nasal concha, maxillary sinus. This is if you took the slice, from front to back. I wouldn't have a general knowledge of maybe the nasal septum on this image and maybe the nasal cavities and your sinus areas. I probably won't ask too much about the osteomeatal complex. This is what it looks like on CT. It looks kind of pretty, kind of weird. It looks almost like some type of butterfly in here. Again, you can see from the CT image of the sinuses that diagnosis is a little bit easier with CT because you can really see fluid. You can really see any type of pathology that may be in there. So you may have to do general x-rays for sinuses due to the fact that the patient's insurance won't pay directly for a CT. or if you've got someone who's had chronic issues with their sinuses, they're probably going to have just a direct CT. They're not going to mess around with x-rays anymore. If they have chronic issues, their insurance is going to pay for them to go to CT. All right, so your anatomy, you have the 4 sinus groups. The lateral projection is the really good one that displays all 4 sets of sinuses. So you are always going to do a lateral sinus x-ray as part of the general routine, always. So you can see the sphenoid right under the sella turcica. It's right here. Your ethmoid located right behind the ethmoid bone back here, behind the nose. The maxillary on the maxilla here. And you can clearly see the frontal. Most everybody, you can see the frontal sinuses here. And here. The sphenoid and ethmoid sinuses on APs or PAs, you just kind of, they're just all here. That's just because you know they're there, but you can't really distinguish one from the other. So they're almost superimposed. This one, of course, is the review from the original slide. So your frontal, sphenoid, ethmoid, and your maxillary. I do want to point out that if you're looking at a sinus x-ray and you see a lot of white in the sinus cavity, most likely that is some fluid in there. A lot of physicians, before the x-ray is actually done, they want the patient to kind of be sitting still and erect before it gets done, just to make sure all the fluid can settle out. But as I said, these are supposed to be done erect. The transoral projection, the open mouth waters, this is a really good one, and I don't know why more departments don't do this one, because it is a really, really great image to be able to diagnose a lot of pathology and to see a lot more with the patient's mouth open instead of closed. But you can see how well the sinuses are seen in this image. And when the mouth is open, guess what? You're getting the teeth out of the way of the sphenoid sinuses. These normally aren't seen that well on a regular waters image because the teeth are in the way. So when you open that patient's mouth, you can see them. It's just a lot better. Like I said, I don't know why more departments don't do this one. Here's your SMV projection for sinuses. Guess what? You probably won't have to learn a whole lot more for this one than you did for the skull. I want to say the CR placement's about the same. So you're in luck. You don't have to relearn this one. But you can see on this one really well the A. Those are the air cells of the mastoid process here. You can see the maxillary, ethmoid, sphenoid. Just skipping through my orbit. All right, so just a little bit of review of the facial bones with the parieto-acanthial waters projection. A is the zygomatic prominence, your cheekbone there. B is the body of the maxilla. And please take note of how it looks on x-ray. So don't just look at the skull, also look at the x-ray image and what you're supposed to see. C is that nasal septum. You can see they're right in the middle. D is the anterior nasal spine. E, let's see where E, zygomatic arch. F is the coronoid process. We haven't gone over that. G is the condyle. That's where the TMJs. And H, the mastoid process. Of course, we all know I is the angle of the mandible, but we're not quite there yet. Here we go from the bottom. This is your SMV projection, your inferior view. Of course, you can see the Palatine process here, B. The horizontal process of the Palatine bone is C. A is those zygomatic arches. When you're doing the SMV for facial bones, and they're specifically looking at the zygomatic arches, this is also called the handlebar view because you can see with the two zygomatic arches, they look like handles, especially in a properly imaged SMV. All right, here we go. This is what it looks like on x-ray. And if you're only doing facial bones, you don't need all this back of the skull. I don't know why they have all of this here. We'll do a few of these. If we can get through most of the paranasal sinuses today, Friday, we'll go over your test. And I'll do a little review for your test on Monday. I believe you have a test next Monday. So which of the following facial bones is unpaired? That is the vomer. 2 maxillary, 2 palatine, 2 lacrimal, 1 vomer. Anterior nasal spine is the aspect of which bone? Maxillary. Palatine process is an aspect of the maxillary bone as well. This is the one we spoke about earlier. Lacrimal is derived from the word meaning tear, not duct, but tear, just because they are associated with the tear ducts, but they're not derived from the word for duct. Which facial bone forms an aspect of the bony nasal septum? That is the vomer. You can kick ethmoid out altogether because it's not even a facial bone. That's a cranial bone. So that, completely takes that one out. You don't have to worry about that one. So the older term, antrum of Highmore, describes the, let's see, maxillary sinuses. Which paranasal sinus is the last one to develop? That is the ethmoid. I want to say frontal and maxillary are the first, then sphenoid, then ethmoid. So that's just an interesting thing to learn, that it's the very last one to develop, that no one has that when they're born. Why babies' heads are so heavy. Weak neck muscles and big heavy heads. These body planes and landmarks, this is exactly the same thing that we went over with skull. So a lot of this should be, oh good, I don't have to learn new stuff. So your glabella, nasion, which by the way, most of you guys got right on the test. I think all of you got it right. The supraorbital groove, superciliary ridge, the IPL, the angle of the mandible, which is the gonion, mental point, very end of the chin, canthyon, right here between where the nose meets the upper lip. Now, when we're doing facial bones and sinuses and mandible, you're going to use the acanthion a lot more than you do the glabella. So we're moving down the face. So your body planes and landmarks are going to be a little bit different. All right, there's your surface landmarks, your TEA, top of the ear attachment, your auricle, the tragus. Again, you guys know the glabella, nasion, but the more you hear this, the more it just becomes part of your vocabulary. acanthion, mental point, and the gonian. Now, I just left this slide in here, landmarks of the orbit, because it's still helpful for other cranial imaging. Your midlateral orbital margin, outer canthus and inner canthus. So inner is the inside of the eye, outer is outside, IOM. Here's your skull positioning lines again. The acanthomeatal line, the AML, we're going to start using that a lot more. The lips meatal line, the LML, we're going to start using that, and the MML. So the GML we're not going to abandon for as we move down the face, but it becomes less of something that you need to be concerned with the lower you get on the face. The orbitomeatal line and the infraorbital meatal line. And so this slide actually says Reed's baseline, which is one of your test questions. What is the older term for the IOML? All right, positioning and technical considerations for your sinuses and facial bones. All right, so we'll talk about erect versus recumbent because we all know that the sinuses have to be done erect. Please say this to yourself all the time. Last year, I had some lab evals with some students from Warner Robins that did their sinuses on the table and failed. You can't do those on the table. Those have to be done erect, even for lab eval. The KVP range, digital, we're more concerned with 75 to 90. 85 is a really good happy medium for sinuses. They are air-filled, so you don't want to necessarily burn those out using too much mass and too much KVP. Minimum of 40-inch SID. Notice that does say minimum. Whenever you're being evaluated for your lab eval, we say 40 because that's easy for everybody to stick with for lab eval. You can absolutely do these projections at 60 or 72 inches. Actually, a lot of radiologists, a lot of departments are moving away towards a 40-inch SID. Originally, it was to help reduce dose to the patient. You didn't have to use as much technique because you were a lot closer. But with these digital imaging now, that's not a concern anymore, really. So you can be further away, actually increases detail. We know that. So most departments are now preferring 60 inches or more for head work. Small focal spot because it is a small part, and shield the radiosensitive organs at will wherever you can. We're going to talk about the 5 common positioning errors. Rotation and tilt. Rotation is going to be the biggest one for head work, especially if you are working on the table. Tilt can get you in trouble a lot if your patient is erect, even if you're doing erect cranial work. Excessive flexion or extension. Remember, you have to position your patient's head by those positioning lines. So you can't just automatically just tell someone to, completely extend or flex their head because every person is different. Or the incorrect CR angle. And a lot of these errors will present themselves depending on the projection. There's some projections where you'll never have to worry about tilt. There's some projections where you always have to worry about tilt. So it's almost unique according to what projection you're doing. So not only do you have to learn all the projections and what all the projections are supposed to visualize and how to position the patient, but you also have to worry about which projection may cause more errors versus another projection. So you get to memorize all sorts of things for head work. Recumbent positions, if it is a trauma situation, you're not going to be able to control that. You have to do what you have to work with. So you can't be, if someone is recumbent, came in through a trauma, even if they, helicoptered in or whatever, how they come in is how you x-ray them until more is known about their condition. The erect positions, of course, air fluid levels. And it's actually kind of neat to see, and I mean, not neat for the patient, but it's kind of neat to see someone sinus x-ray and they have fluid-filled sinuses. I mean, it's bad for them, but you can tell that, they're really sick. They don't feel good. Also, erect positions are easier for hypertensive patients, especially if you've got a larger patient or a more elderly patient that cannot lay on their belly, or they really can't be in a recumbent position for very long for breathing reasons or for whatever reasons they may have. So it is always a good idea to know how to position head work on table and at the wall bucky. Positioning. What time is it? I'm watching my time too. We got about 10 more minutes. Lateral facial bones. The CR is perpendicular, center to the zygoma. Notice this looks a lot like the lateral skull. So all you have to do is bring that CR to the cheekbone. That's all you have to do. You don't even have to do 2 inches above or 2 inches below or any of that stuff. You just right on the cheekbone, perpendicular. Couldn't be easier. Whenever I do lateral facial bones, I collimate to just beyond the EAM to make sure I get all of the facial bones. Notice that the back of the skull is cut off, but who cares? You're not looking for the back of the skull in this X-ray anyway. If they wanted the back of the skull, they would order a lateral skull. But you're only concerned about facial bones or sinuses. Your zygomatic bones in center of the radiograph, because that's where you center. Where you center should be the center of your radiograph, right? We all know that. No rotation or tilt. You can tell rotation or tilt by looking at your sella turcica. And you can also look at your mandibular condyles to see if they are superimposed like they're supposed to be. Now, real quick, if someone has rotation, let's just use the superimposed condyles of the mandible. If someone has rotation, the condyle will be where? Up or below or beside if it's not superimposed? Just anybody.
Beside?
It'll be beside. Yes, sir. It'll be beside. If you have tilt, one will be above or below the other, depending upon what location, what direction it's tilted. So if someone has tilt, you're going to see whatever you're supposed to be looking for to indicate that you do have superimposition. Just look to see where it's at. If it's above or below, you've got a tilt problem. If it's next to, you got a rotation problem. Here's your waters. I know that you've heard everybody say a waters is a waters is a waters. I'm so sick of that expression, but it's true. It's nothing special from sinuses to facial bones or nasal bones. A lot of departments do a waters for nasal bones as well. It's the same. And you have to make sure the MML is perpendicular to the IR. So you have to be careful not to overextend your patient's head. Some people are like, act like you're a head above water, trying to be a head above water. Well, that's fine, but make sure you don't completely extend that patient's back to where the MML is not perpendicular, because that's not good. A lot of techs, I've heard them tell students, just, make sure you stretch their neck out as far as it'll go and just put their chin on the board. Well, for some people that might not work. As long as the MML is perpendicular, you don't have to, extend that patient's head back all that much. It's very uncomfortable to ask a patient to do that. And your CR is perpendicular, exit the acanthion. So now we're worried about the acanthion. And you can see from the small diagram at the bottom of the image, the erect position, the CR, and the patient's MML being perpendicular to the IR. You can see where the CR is supposed to enter and exit the acanthion. If you're doing what you're supposed to be doing, This is not hard. The waters is not very hard. All right, here's your erect parieto-acanthial. It's even in the name. I know people call it by waters, but it's even in the name, the parieto-acanthial. So enters the parietal area, exits the acanthion. Horizontal CR, 37 degrees OML and IR. So the MML is perpendicular to the IR. Same thing. Doesn't matter if they are erect or recumbent. This is a beautiful waters image. As you can see all those nice sinuses there. Now, remember, this is a closed mouth. I don't see the sphenoid sinuses here because that's not a transoral. That mouth is not open. So this is a great diagnostic image, but it also, you can't really see the sphenoid sinuses because the mouth is closed. But the peaches ridges, remember those are the very, very dense. They need to be below the maxillary sinuses, okay? If you don't have your MML perpendicular, those peaches ridges will not be below the maxillary sinuses. This projection shows those maxillary sinuses beautifully. So if that's part of the reason to do this projection, make sure that that's what you can see. That makes sense. So if your peaches ridges are not below, you need to determine if you need to extend your patient's head more or bring it back a little bit. No rotation. Here's your Caldwell, your PA axial. Okay. We're just going to keep the Caldwell. It's a good projection. We're just going to keep it for this too. The OML is perpendicular, CR 15 degrees Caldat, exit the nasion. This is, if you notice on to the side of the slide, that is part of a routine. Most departments are going to do a lateral, the waters, and a Caldwell. They may do just a straight PA as well, but it's not very diagnostic. So typically these are the ones you're going to see. This is the PA axial of the Caldwell. This one doesn't look too much like a Caldwell. I'm not sure this is a Caldwell, but it was in the slide, so I left it. But the peaches ridges should be in the lower 1/3 of the orbits for the Caldwell, because you're really, really looking at the frontal sinuses and the ethmoid sphenoid sinuses, even though they're sort of superimposed over one another. So again, you want to get the peaches ridges out of the way. Here's a modified waters. This is some people, you're just not going to be able to get their MML perpendicular how you need it. And so this is going to help with that if your patient just cannot do what you're asking them to do. Also, it's good to demonstrate possible orbital fractures in any type of foreign body. This one's good. This one, the LML is perpendicular to the IR, not the MML, the LML. The OML will then form a 55-degree angle to the IR. So you can see that they're not extending their neck as much as they would for a typical waters. This is a special projection. You're not going to do this one for every single one that comes in the door. So this is the modified. Notice that you can't really see the maxillary sinuses as well because the patient's LML is perpendicular, not the MML. So these peaches ridges are in the lower 1/3 of the maxillary sinuses. So you can really see the orbital floors. And if someone has an orbital fracture or any type of foreign body in the eye, you can see it on this one. It's really good for that. Nasal bones. I love nasal bones. They are easy to burn out because they are so small. But the routine is you're going to do both laterals, right and left lateral, and a waters. I've never had to do a Caldwell for nasal bones. Typically, both laterals and the waters, you'll get it every time. Maybe a tangential, but again, that's not something that you really have to do all the time. If it's that bad, they're probably gonna cart them off the CT anyway. Here's your little nasal bones. Now, this little bone is so small, your CR needs to be perpendicular to the nasion, a ½ inch below the nasion. The interpupillary line has to be perpendicular to the IR, but your collimation, with CR, you could collimate down just to the nasal bone area, but digital doesn't like that tight collimation. So you may have to keep it open a few inches instead of like so tight to the nasal bones. But it's so small. This one you need to really set your own technique for because you can burn out the nasal bone quite easily. And it's very difficult to get a bone that's this long directly over a center cell chamber if you're using AEC. Here they are. They're cute little nasal bones. They're adorable. The nasal bone has to be centered, no rotation, close collimation, as close as you can get away with, but still get an optimal image. Because like I said, digital doesn't really like that really super tight collimation, and that's such a tiny bone. All right, this is going to be our last slide before we get back to it on Friday. The superior-inferior tangential axial. This one I have never done before. This looks ridiculous. The IR is perpendicular to the GAL, and the CR is parallel to the GAL. Basically, you are going from top to bottom of this nasal area, but you also have to be careful not to get someone's forehead and head all in the way. So this is a very difficult projection to get done because you have to have this patient, over the film, and their head has to be positioned a certain way so that you don't get forehead all in your nose. But it will demonstrate possible medial lateral displacement, but a waters will too. This is a special projection. This is not something you would normally do, but this is what it looks like. This isn't a perfect world. This is what it looks like. You can see the two nasal bones with no superimposition. You can also see the cartilage there. But again, I don't even, I mean, I know I could figure it out, but this projection just looks weird. All right. All right, I'm just stopping the recording.